Welcome to Alabama EMS Challenge. Appreciate y'all being with us today. We've got Dr. Julie Brown's going to be talking about central nervous system trauma, followed by Dr. Payne. So we'll go ahead and get the ball rolling.
All right. Good morning, all. I'm Julie Brown, one of the EMS fellows at UAB. Dr. Ferguson couldn't be here this morning. He's at a meeting, but wanted to remind you of a couple things. We will be at Birmingham Station 2 on March 23rd, and we are having a protocol review class for the new protocols at BRIMS. There's 2 sessions this evening, and then I think that there's some more sessions tomorrow that you can find on the BRIMS webpage. All right, we're gonna get started. Have mercy. I think I alarmed them. Yeah, that wasn't me.
You're welcome. I just put that song back.
Welcome to CNS injuries. All right. So we're gonna start with the case. So you have a young female. You get called out for just a young lady that's laying in the street. You get there and you see this. So there's like a 30-year-old female. She's laying on the ground unresponsive, about 10 feet away from a pretty damaged vehicle with obvious head and facial trauma. So we'll come back to this case throughout the lecture and talk about some different points. Oh boy, I'm sorry. I went way too far. All right. So these are the things we're going to talk about. We're going to talk about TBI, what is it, a little bit of statistics about it, the signs and symptoms to look for, the pathophysiology, how we classify TBI, and then what we should be doing in the field to assess these patients and how we can treat them. All right, so TBI is an alteration in brain function or other evidence of brain pathology that's caused by an external force. So that external force could be a blunt impact, so your head striking an object or another object striking your head. So if you fall and hit a cabinet, or if a baseball bat hits your head, it could be a penetrating injury like a gunshot wound or a stabbing. It could be a blast wave from like a bomb or an accelerating, decelerating force. So things that would happen like if you were in a car accident. Really, it's hard to know what the global burden of TBI is or traumatic brain injury because a lot of people don't go to the hospital. So there's a lot of patients with mild injury that don't think anything's going on, so they don't seek medical care. But the data that we do have from the CDC in 2014 says that there's about 2.5 million ED visits related to TBI and about almost 300,000 hospitalizations and about 57,000 deaths related to TBI per year. And that doesn't include patients that don't go to the hospital. It doesn't include patients who went to an outpatient clinic to like an urgent care. It doesn't include patients who are seen at the VA or patients who are in the military, which encompass a good number of patients. So the leading causes of traumatic brain injury in the US are related to falls. The second most common is motor vehicle accidents versus being struck by or against an object, like pedestrian versus auto, or getting hit by like a baseball bat. The statistics for, or the incidence or prevalence of TBI related to self-harm is actually going up, and then homicide is also going up. Most patients that have a TBI, the majority of them are older patients. They have the highest morbidity and mortality, the highest number of ED visits, hospitalizations, and deaths. There's also a high rate in very young patients, so 0 to 4, and then kind of younger adults, 15 to 24 years old. There's some other risk factors like lower socioeconomic status, alcohol and drug use, which makes sense, and then underlying psychiatric and cognitive disorders. So what should we be looking for? So if a patient has a traumatic brain injury, they might have physical symptoms like headache, nausea, vomiting, problems with their balance, dizziness, fatigue, changes in their vision, light or noise sensitivity, numbness or tingling in their extremities. They might have cognitive problems. They might have trouble concentrating, trouble remembering things. They might be emotional. They might be sad, nervous, irritable, And then they probably are going to have difficulty sleeping. So maybe they're getting more sleep than normal, maybe less sleep than normal, or they're just very drowsy. So with the pathophysiology of traumatic brain injury, so there's a primary injury and there's a secondary injury. The primary injury occurs at the time of the trauma. So they're in a car accident and they get a head bleed. That's their primary injury. And that happens just immediately. And then the thing that we can try to help prevent is secondary injury. And that happens like hours to days after the initial trauma. And that's usually due to hypoxia, hypotension, hypothermia, hypoglycemia, hyperglycemia. And then all those secondary injuries can lead to, cell death in the brain, swelling in the brain, and then increased intracranial pressure. So a big aspect of preventing that secondary brain injury is really avoiding these secondary insults. So things that we can treat. We can try to prevent hypotension. We can prevent hypoxia. We can try to prevent fever and treat seizures. If a patient's seizing, they have an increased metabolic demand. So that brain tissue that's already hurting has increased activity and can make it worse. We can try to prevent elevated intracranial pressures and then hypo and hyperglycemia. So there's a couple different ways to classify traumatic brain injury because it really just encompasses a lot of different things. So we can categorize it by clinical severity, the mechanism of injury, the pathophysiology, and then age and comorbidities also play a big role. The most common way to classify traumatic brain injury is by using the GCS. But the big point here is that it's very limited by confounding factors. So a patient can be intoxicated, making their GCS lower, and maybe they don't actually have a traumatic brain injury. Maybe their leg also got cut off during the accident, so we're sedating them. Maybe we intubated them because they have a lot of facial trauma, and then they're paralyzed, so we can't get a great GCS. But in general, a GCS of 13 to 15 means the patient has a mild traumatic brain injury. 9 to 12 would be moderate, and 8 or less would be severe. And then just a reminder of how to calculate the GCS. So it's based on your eyes, your verbal response, and your motor. So the lowest score you can get on the GCS is a 3. So you get 1 point for being unresponsive completely. For eye opening, your eyes will be open spontaneously, you get a 4. If they are open to verbal command, you get a 3. If they respond to pain or eyes open to pain, you get a 2, and then no eye opening is 1. Verbally, if you're alert and oriented, they're talking to you, they make sense, they get a 5. If they're a little bit confused, they get a 4. Patients who are intoxicated often get a 4 because they're just confused. They can say inappropriate words. They might make incomprehensible sounds like moaning, or they may have no verbal response. And then motor, and I have some pictures of these. If it's a 6, they're obeying commands. They can show you 2 fingers. A 5 would be that they're localizing to pain. 4 is withdrawing to pain. 3 is a flexion response to pain or a decorticate response. 2 is an extension response to pain or a decerebrate response. And then 1 is none, no response at all. So as you can see, you get a 6 if you can obey commands. 5 if you localize. So if you're pinching them on their right hand that has an injury and they try to grab your hand away with their left hand. So that means they're localizing. Versus withdrawing, if you prick their finger and they pull their hand away, then that would be withdrawing. Versus a flexion response is where their arms are kind of up next to their body versus extension, their arms are by their side. All right, so back to the case. So about a 30-year-old, she's unresponsive after a car accident. She has she has obvious head and facial trauma. Her eyes are not opening when you speak to her or you apply a painful stimulus. How many points does she get for eyes?
She's not responding.
She's not responding, yeah.
Not responding at all.
Oh, yeah. Yeah, so she gets a 1. So she's moaning. So what does she get for verbal? Yeah, 2. So incomprehensible sounds. They're moaning or groaning, they get a 2. And then if she's moving her hand away when you grab her finger. So
Withdrawal.
yeah, withdrawals. Yeah. So she get a 4. So 1 + 2 + 4 is a 7. Will be her GCS. All right. So we classify patients with traumatic brain injury based on their GCS. You can also classify them based on their imaging, their CT or their MRI. Things that you can see are like skull fractures, which you can see in this image of the CT of the head. This should be all connected. So there's a fracture there. You can have epidurals, subdurals, and I'll show y'all some images of those, subarachnoids, cerebral contusions, which are just bruising of the brain, and then other bleeds. You can also have something called DAI, or diffuse axonal injury. A lot of times those patients may not have any imaging findings on their CT of their head, but they're just profoundly like comatose and you just don't know what's going on, and they have DAI. All right, so first, just a reminder of what makes up the kind of layers of your head. So you have your bone, which is your skull. Underneath your bone, you have your dura mater, which is kind of directly adhered to your bone. And you have your arachnoid matter, and then your pia mater is directly adhered to your brain and really hard to get off. And you have some blood vessels in between those. So we're going to talk about epidurals and subdurals. So an epidural hematoma is going to be above the dura, so it'd be between the bone and the dura, versus a subdural would be below the dura, so it's between the dura and the arachnoid. All right, so an epidural hematoma is usually a patient that falls and hits their head right in their temporal bone area. So they get hit with a baseball bat, they get a baseball that flies into their head or any other kind of ball. So it's usually there's a temporal bone fracture kind of right here, and then they have a tearing of their middle meningeal artery. So it's an artery, so it's a rapidly expanding injury. And so on a CT scan, you see this like kind of lens-shaped bleed right here. So this white should not be here. This is all blood. Usually these patients don't have a lot of underlying brain injury, but the important thing about epidurals is these patients can seem fine at first. So they have their initial injury, they have a lucid interval, so they're totally with it, nothing's wrong with them, and then all of a sudden they decompensate. So I had a guy in the ER who had fallen like 20 feet, came into the ER, didn't get evaluated, left AMA, came back a couple hours later, completely obtunded and had a huge epidural. These patients usually go to the OR to get those evacuated. Versus a subdural, so subdurals are below the dura, so these are damage to bridging veins. So we most commonly see these in older patients, and that's because as you get older, your brain starts to atrophy and get smaller, and so it stretches out those bridging veins, and so they're more susceptible to break. So these are more of a slower bleed because they're veins. So it's more of a crescent shape, so this white part right here, and there's often underlying brain injury. So with this subdural, you actually have shift. So you should have 2 ventricles right here, but you can't really see this one over here. So it's all shifted. That brain is all shifted because you have increased pressure. All right, so just a review of that. So if you have an epidural hematoma, usually it's in your temporal bone area. You have a skull fracture. You kind of tear this middle meningeal artery and you get this rapid bleed. And so it's pushing the dura away from the skull. Versus a subdural, could be like an older patient, you tear these kind of bridging veins right here, that gets stretched out as you age, and then you get some bleeding. All right, versus subarachnoid, sometimes you might hear somebody say like the star of death. So patients who have an aneurysm can have a rupture and get a subarachnoid hemorrhage, which is kind of what this probably is. You can also have traumatic subarachnoids, which are bleeding just of smaller vessels that can be devastating, or the patients can be okay. Important thing about subarachnoids is if the patient's in a trauma and they only have a subarachnoid, you kind of wonder, did they have a rupture of an aneurysm prior to the trauma that caused them to like have a car accident or a fall, or did it happen after? And then you can have cerebral contusions, or really just bruising of the brain. So it's just bleeding a small vessel. Usually it's kind of in the front part of the front lower part of the brain, which is what all these white spots are. This is the most common trauma-related head bleed. And then we'll talk a little bit about DAI, just because these patients can have no evidence of abnormality, at least on a CT of their head, but they're just this profound coma and you don't know why. So this is your brain. So you have white matter, which is on the inside, and then you have gray matter, which is on the outside. Your gray matter has your cell bodies. So cell bodies basically make signals in your brain. And then those signals travel down an axon, which is in your white matter. Okay, that makes sense. And so with diffuse axonal injury, it typically involves that gray-white matter junction, so where the cell bodies go into the axon, so where that signal is being made to where it's being transmitted down the tract. It's usually secondary to a shearing mechanism. So if a patient was in a car accident and they had an acceleration-deceleration injury, if they were going really fast and their head shook forward and backward, they can get this. They often present really with profound coma. CTs can see it occasionally, which is what this is, but usually you have to get an MRI for these patients. And then interventricular hemorrhage, these can be really bad. So you get bleeding into the ventricles. So these should be just open and black. The problem with this is in your ventricles, you have cerebrospinal fluid. And if you have blood taking up that place of the fluid, there's nowhere for it to go. So it just builds up, and the pressure in your brain gets high. And then that's when patients herniate. All right, so just a review on that stuff. So traumatic brain injury is just an alteration in brain function due to some external force, blunt trauma, penetrating trauma. It's most common in the elderly, the very young, and then kind of young adults. Most commonly due to falls and traffic collisions, but self-harm and homicide is getting up there. Usually presents with like headache, nausea, vomiting, changes in vision, mood changes, sleep disruption. There's a primary injury that occurs at the time of the trauma versus a secondary injury that happens a couple of hours versus days later. And then we can classify TBI based on GCS, so mild, moderate, or severe, or by imaging studies. So if you look for like epidural, subdurals, or other bleeds, which would also obviously happen in the hospital. All right, so if you have a patient like the one in this case, 30-something-year-old who's in a car accident, who's unresponsive, what are we going to do with her? So obviously first, do your ABCs, make sure the airway's intact, make sure they're breathing, make sure their circulation's okay, immobilize their C-spine if they're in a blunt trauma that is scary enough that you're going to trauma alert them, and then we'll get to D for disability. So for C-spine mobilization, don't let your patients do what is happening on the first image, because if they do that, then they probably don't need their C-collar. But just assume all patients with blunt trauma have a C-spine injury. That is like major trauma. So if you have a low speed MVC, the patient has absolutely no neck pain, they want to go to the hospital because their wrist hurts, they probably don't need a C-collar. But if you're going to trauma alert somebody, they probably need one. If a patient has isolated penetrating trauma and they didn't have a blunt trauma afterward, then they probably don't need a C-spine. That's actually associated with a higher mortality in those patients because they usually don't have fractures. So if a patient got shot while they're driving their car down the road and then they got to an accident that was pretty severe, they might need a collar. If they just got shot, then they probably don't need a collar. That makes sense. All right, so what happens if you need to maintain an airway with a patient who has a collar on? So this is actually kind of interesting to me because I usually intubate with a collar on, but what is recommended is that you remove that anterior part of the collar. So just take the front of the collar off and somebody holds C-spine, because even like with bagging a patient with a BVM or intubating, you're moving that neck so much, even when it's in a collar, that patients have worse outcomes than if you just have somebody hold inline stabilization. All right, so you did your ABCs, you got a collar on them, and then you get to D. So what are we going to look for? So we're going to determine their level of consciousness, their GCS, look at their pupils. Are their pupils equal and reactive? If they're unresponsive and one pupil is blown, you might be more worried that they have a more significant injury, and then look at their gross motor function and their sensation. Once you have stabilized their ABCs, you're in the back of the truck, you're transporting the hospital, you can start looking for other injuries. So you can just palpate their head, their skull, see if it feels like they have any depressions in their skull, like a fracture. Kind of look at their face, see if they have any obvious bony abnormalities in their face that could potentially be an airway problem later. Be careful when you're palpating somebody's scalp because there could be glass or other foreign bodies in it. And then you can look for any signs of a basilar skull fracture. So I'm sure you've seen these like raccoon eyes, which are just bruising around the eyes, or a battle sign, which is bruising behind the ear. Those are suggestive of a basilar skull fracture. So a fracture of the temporal bone that's kind of right underneath the eyes. And then here's some images of that. So the battle sign and the raccoon eyes. So you've got that bruising behind the ear, and then the bruising around the eyes. A lot of times these don't show up for about 24 hours, but if you have a patient who fell yesterday and now has a really bad headache and this, you might be a little bit more worried about them and want to transport them. All right, so what are we going to do for these patients? So patients who have mild traumatic brain injuries, so think GCS 13 to 15, what we would recommend that obviously all patients that with a suspected TBI get transported to the hospital. Once they're evaluated, we recommend at least 24 hours of at-home or inpatient observation. We would recommend patients get admitted, if they have a depressed GCS, if their CT head is abnormal, if they're having seizures from their traumatic brain injury, if they have abnormal bleeding, so if they're anticoagulated, they have a higher risk of a late bleed. Obviously, if they have a neurologic deficit, if they're having tractable nausea and vomiting, or if there's no one to watch them. And then if they do decide to stay home, so if you have a patient who has a GCS of 15, they have a headache after they had a fall, but they don't want to go to the hospital, things that you could, you offer to take them, but they don't want to go, things that you can tell them to look out for are if there's someone else with them, that they're not waking up when they should, they're having worsening headaches, they're confused, they're somnolent, they're having seizures, if they're having trouble seeing, recurrent vomiting, obviously if they're having incontinence or weakness or numbness, they probably need to go to the hospital. Seizures with mild traumatic brain injury are usually self-limited, so you can treat if you have a patient with a GCS of 14 that just had a fall and they are having a seizure, obviously treat the seizure. And we treat those acutely because we worry that they'll progress to status, and then that increases your metabolic demand and then can increase your secondary brain injury. So we want to prevent that. But there's really no role for prophylactic medications in somebody who's not seizing for a mild TBI. And then obviously if they have evidence of bleeding or a skull fracture, then we would consult neurosurgery. So these patients with mild TBI, they need at least 24 hours of physical and cognitive rest and a resolution of their symptoms. And then they can kind of gradually return to school or work. The problem I think arises where, so you have a football player who gets a concussion, who, feels better, but maybe still has a little headache, a week later, but they want to play in the game. And then they play and then they put themselves at risk for another concussion. And then there's worse long-term effects from that. So we try to prevent or try to avoid any activities that can increase your risk of a concussion later. Usually patients with a mild TBI do well. They can get post-concussive syndrome where they have kind of more long-term headache, dizziness, and other symptoms. Usually their symptoms are worse at 7 to 10 days, but by a month, most of their time, the symptoms have gone away. Most of them don't have permanent symptoms. All right, so the important thing, like where we can act in the pre-hospital setting, is a moderate to severe TBI. So think GCS of 3 to 12. So the big things that we can do is prevent hypoxia and hypotension. So if a patient has a low SAT, so less than 90, or a blood pressure less than 90 systolic, that's associated with worse outcomes. There's actually studies that show that a systolic less than 110 is still associated with worse outcomes in traumatic brain injury. So things that we can do, we can manage their airway. So we want to keep their stats up. You can put them on supplemental oxygen. Think about intubating them earlier. If you're further out, call a helicopter or just transport them as fast as you can. If you can't, RSI them. Think about intubating them if they have a depressed GCS, so less than 9, so less or 8 or less. If they're not protecting their airway, if they're not having good chest rise, even though you have put in a nasal trumpet, you've done a draw thrust. Obviously, if they have signs of impending herniation, which we'll talk about, obviously you would want to intubate those patients if you have a long transport time, or if you're giving them supplemental oxygen and they're not getting any better. For just a suspected TBI, you don't have to hyperventilate these patients. We only want to hyperventilate if we think that they're herniating. We can manage their blood pressure. So fluid resuscitation, so you can give isotonic crystalloid if they have no obvious other trauma. So their abdomen's soft, it's non-tender, they have no other extremity trauma that seems to be bleeding, doesn't seem like they have any chest trauma that's bleeding. You just think it's the head. You can give them isotonic fluid. You can give them blood if you have it. I would say if they're still not responding, you can try to use vasopressors and then obviously TXA. So with ventilation, with just suspected TBI patients that don't seem to be herniating, we want to avoid hypoventilating and hyperventilating. The problem when you hyperventilate somebody, you hyperventilate them, their CO2 goes down, then they can get cerebral vasoconstriction, so the blood vessels in their brain constrict. And so that decreases the blood volume in the brain, but it can cause secondary ischemia, and that can worsen their outcomes because we want to make sure we're getting enough blood flow to that damaged tissue so that it can recover. But then if their CO2 is too high, it can elevate their intracranial pressure. So if anybody's intubated, obviously use End-Tidal. Anti-epileptics or anti-seizure meds are all recommended for all moderate to severe TBI because these patients are such a high risk for status that you want to prevent that. Other things that we can do, check their blood glucose, because we can treat that in the hospital. Want to try to avoid fever. You can elevate the head of the bed to decrease their pressure, and then obviously appropriately sedate somebody and then paralyze them if you have to. If somebody is, you're critical care, you can RSI somebody and they are obtunded, but, still fighting you. I would probably try to sedate them the best you can because you don't want their blood pressure to be too high, but obviously you want to be careful and make sure it's not too low. Things that we can do in the hospital, if they have bleeding, the surgeon can go in and surgically evacuate it. Take off. Some patients will get an EVD or an external ventricular drain, which is what this is. So a lot of times they'll use these in like subarachnoid hemorrhage or like an interventricular bleed where there's that bleeding in the ventricles, basically to let your CSF drain out so the pressure in your brain doesn't go up anymore. So what do we do if somebody's herniating? So if they have pupil asymmetry, so one pupil is fixed and dilated or one pupil is blown, if they're having decorticate, which is that flexion response, or decerebrate, which is that posturing response, the extension response. If they're having Cushing's triad, which is hypertension, bradycardia, and respiratory differences, like a respiratory depression, basically, then you could think that they might be herniating because it would be strange in a trauma patient to have hypertension and bradycardia. Acutely, what can you do for them? If they don't have an airway, intubate them, elevate the head of the bed. You can briefly hyperventilate these patients because acutely you're trying to save their life, right? If they herniate, then there's the secondary injury doesn't matter because they're going to be dead. And then some critical care will have osmotic agents like mannitol, and the hospital will use hypertonic saline. So prognosis for these patients, there's a 30% risk of death with moderate to severe TBI, and a lot of these patients will have an increased mortality for at least 13 years if they have a severe TBI. But a lot of these patients will do well. They can regain independence and have a functional recovery. They might be living with a trach for a while, but a lot of times these patients get decannulated. So this is the new protocols that will go into effect April 29th. So this is the trauma one. So you do your ABCs, and then you get to your D. And here, so it's essentially saying to avoid hyperventilation unless you think that the patient is herniating, and then you can hyperventilate. And then things that we can use are like TXA, 2 grams over 20 minutes, or put it in a bag and just let it hang. All right, so back to the case. So we had this 30-year-old female. She was in a car accident. Her GCS is 7. So these are her vitals. So she's a little tachycardic, a little hypotensive, she's hypoxic, and she's not breathing but 8 times a minute. She has obvious facial and head trauma, but you don't really see anything else. You don't really see any chest or abdominal trauma, no trauma of the extremities. So what do we want to do about her airway? Is she maintaining it? No, she's definitely not. She's breathing 8 times a minute and her SAT's 85. So I'd probably put her on an on-rebreather while you're like getting ready to intubate. If she has a gag, it makes it very, if she does not have a gag, it makes it very easy to intubate versus either driving faster to the hospital or calling for a flight crew. So she's not protecting her airway. Still want to secure it. So what about her breathing? So if we intubate her, say she has good breath sounds bilaterally, but then what do we think about her circulation? Blood pressure is 90 over 55. Would you want to give her some fluids or blood if you had it? What other med can we give her? We just talked about. Yeah, you can use vasopressors. What's another med? It's newer. Yeah, TXA.
If you're going to use vasopressors, what would you do based on our form?
I would probably give epi. If their heart rate, I would probably try to give fluids first, and then blood if you have it. A lot of times in the trauma bay, at least, if we have a trauma patient that we don't know if they have any other injuries, we give them blood until we know. And then if it's just a head injury, we just give them isotonic fluids. In the hospital, we start them on a lot of times norepi. Sometimes we'll start them on phenylephrine. It just depends on what you have, because you just want their blood pressure to be up, but you don't want their heart rate to go, sky high. But I don't think
HDMI. I got it. Got it, both.
it's okay.
Wrong at all.
Somebody's trying to join in the discussion.
Sorry about that.
But yeah, I would probably, if you have the ability to use push dose epi, I'd probably use that. I mean, you could use dopamine if that's the only thing you have. I would just be wary of the heart rate. But obviously, the blood pressure is the problem that you're trying to fix.
So the push dose says epi here is definitely one.
Yes, yes. Don't use cardiac epi. Don't use anaphylaxis epi.
That's the first half of this.
Yeah.
We can use post-dose epi for hypovolemic shock. Is that what you're getting at?
For hypovolemic shock. So the thing you have to determine is this hemorrhagic or is this hypovolemic? So with the traumatic brain injury, it depends. It depends on what their mechanism of injury was. So if they are in a bad car accident, they have bruises all over and they're obtunded, then you would worry it's hemorrhagic shock, right? Yes, I probably would not use pressors unless that's the only thing you have besides fluid to get them to the hospital. You got to use what you can because you don't want them to die. But you're not, the problem is that you're losing blood. So if you have blood, I would give it. That versus somebody that just gets hit in the head with a baseball bat or with a flying baseball, then that's probably just going to be head trauma, right? That's not going to be other extremity trauma. So I would you can use fluids, and I would use pressors then.
Wouldn't it be pretty odd though to have an isolated head injury and the patient be hypotensive in the early stages?
I mean, yes, but it can happen, especially if they're in the process of herniating, they're already starting to herniate, and that hypertension response is already starting to decline.
Yeah, we just got, so it puts us in
Yeah.
a weird spot because we don't want to give too much fluid if they're
If it's
hemorrhagic,
Yeah.
right? Because we don't want to dilute the clotting factors and all the.
I would say I'd kind of err on the side of giving blood if you have it. First, for any kind of trauma, unless it's just isolated head, then it's probably not hemorrhagic. But obviously most people aren't gonna have blood, so you do what you gotta do to keep them alive until you can get to the closest hospital. But yeah, it would be odd to have isolated hypotension, but that's one thing that we can fix, right? There's not a lot of other things that we can fix about head trauma. All right. So we already talked about that. Suspect that she has a traumatic brain injury. Avoid any other secondary insults. So summary, focus on your ABCs. When you get to D, determine their GCS, look at their pupils, see if they're moving all their extremities. If they're not really responding to you or following your commands, you can just see if they're moving all their extremities. A lot of times you can at least see them kicking or fighting. Things that we can focus on are preventing secondary brain injury like hypotension or hypoxia. And then if you think that they're herniating, you can briefly hyperventilate them. That's it. A lot of the memes for traumatic brain injury aren't very nice, so
Yeah.
that's all I got.
So we did have one question come in.
Okay.
It says, so I was taught not to use a nasal trumpet in any patient with suspected head injury,
If you
including
suspect
TBI.
that they have facial trauma, then no, don't use a nasal trumpet.
Yeah, so the difference there is facial trauma versus
Head trauma.
head trauma.
If they have obvious bleeding of their face is all jacked up, I would just avoid a nasal trumpet. If they got hit right here and they have no other obvious facial trauma, then you can use one.
So it really would be any of the signs or indications of any of the Lefort fractures in the
Yes.
face, right?
Yeah. If you're touching their face and their bones are moving all over the place, don't use the nasal trumpet because then you worry it's going to go up into the brain. And it's happened.
So one thing that's confusing for a lot of EMS folks is the issue of concussions.
Yeah.
And we get put in a tough spot on that sometimes because we go to athletic events for high school or college. And some athletic trainer or coach says, hey, this person has a concussion. Can they go back? Can they still play? They kind of want to force us to make a decision. So what is a concussion, and is that categorized as a traumatic brain injury?
So it is. So there's some conflicting information out there. So some people will say a concussion is a mild traumatic brain injury, so a TBI or a GCS of 13 to 15. Some people will call that a concussion. Some people will just say the constellation of symptoms. So the headache, nausea, vomiting, trouble focusing. Some people will just call that the concussion. And I would say if a patient has a concussion, like a football player, and the athletic trainer tells you that that's what they think it is, I would say, no, they can't play. And that's on you because you just told me you think that they have a concussion. You're like, I think you could offer to transport them if they think that that's what's going on. And if they refuse, that's on them, but you told them that they shouldn't be playing because I don't think they should.
Yeah, so a lot of times it's based on mechanism of injury, right?
Yeah.
Like a basketball player jumps up and gets their feet knocked out from under them and lands on their head.
Yeah.
So then they come off the sidelines, they really don't at least admit to any signs or symptoms.
Yeah. Yeah.
So based on mechanism of injury, hey, we all just saw his head bounce off the floor.
Yeah.
Is that kind of by definition a concussion or not?
It depends on if they have symptoms later. So the problem with that is that you would probably want to take them out of the game because if it is a concussion, if they start developing symptoms later and then they fall again, then they're causing a secondary injury to their initial injury. So I think it's hard to say because they might not have symptoms initially. But yes, it could be a concussion.
So one thing to remember is that concussions are not diagnosed based off of CAT scans.
Yeah.
We hear that a lot, in the public. Oh, I just want to get a CAT scan to see if I have a concussion, right? That's not how you diagnose concussion. It's based only on clinical findings, okay, just your symptoms. A lot of athletic trainers there's actually a scoring system for concussion. So based on the athlete's symptoms, that's how they diagnose a concussion on the sideline. There's an excellent sideline diagnostic tool you can look up. But the rule is if there's any symptoms of a concussion, the athlete has to be withdrawn from play for at least 24 hours, okay? And then they'll have a reassessment. So if the patient has any symptoms of concussion, they can't go back into play for at least 24 hours.
An athletic trainer should know that.
Yeah, and most athletic trainers know that. So if they're coming to you for questions, you know, if the athlete has any symptoms, and you know, they might try to hide it, right? Because they want to get back in the game. So you kind of have to be objective somewhat. But you have to go off of just their symptoms alone. And that's kind of what most athletic trainers will do.
If I'm not mistaken, the Alabama High School Association, they define, their definition of concussion is headache after contact. You automatically go into their protocols.
Yeah, it's
So by their own admission, I mean, if you got a headache after
Yeah.
you took a leg,
That's
you're
what it is.
out.
It's any symptoms, unless you are totally asymptomatic, then you can go back and play. But if there are any symptoms of concussion, 24 hours reading out.
And if they passed out, definitely don't let them go back and play.
In the throwing up.
Yeah.
I gotta get it.
So I understand what you're saying, but we shouldn't de-emphasize the value of a scan to eliminate the other possibilities like epidural and
Yes, of
subdural.
course.
Oh, yeah.
Right, so
Yeah.
if you have a concern for a more serious TBI, of course, CT. But if somebody says, I want a CT to see if I have a concussion, that's not
That's
the
not
right
correct.
thought process.
Got you.
Because they could still have, they can have a small bleed on their CT, but still have a concussion.
Yeah.
And still have like a mild traumatic
You
brain
can have all the
injury.
above, yeah.
So on the intubation, for those services that that don't have RSI capabilities, which is gonna be most of the people listening to this, right?
Yeah.
So is gag response, is that gonna be our primary sign as to whether or not to attempt intubation? Because a lot of times head injury patients are pretty obtunded
Yeah,
and you think they're unconscious until you try to intubate.
yeah.
And then they,
I would say if they are fighting you and you try to intubate them, I would not do it. You can just bag them. It's unfortunate if you're bagging for 20 to 30 minutes to get to a hospital, but it's safer than trying to put an airway and then they aspirate.
so you mentioned, I think mannitol, but any other new drugs coming out in the protocol, that apply to TBI? Of course, TXA, which I know is controversial, right? Because the study was published. I think a lot of us participated in that study. And the study didn't really show any advantage to TXA,
Yes,
but it also didn't show any harm.
yes.
So,
Not a lot of downsides to trying it,
yeah,
but that's what's in the protocols. So that's what
right.
I taught. But yes, TXA is really good for hemorrhagic shock. Maybe not as good for TBI. We don't know. It doesn't really show a lot of, there's not a lot of downsides to trying it, especially if the injury was less than 3 hours old.
So I guess maybe the part of the thought pattern there would be if they're bleeding somewhere else
Yeah, yeah.
associated with the same traumatic event.
So if they're in a car accident and you think that they are in shock, I mean, it could be from their TBI, it could be because they are bleeding elsewhere, so you would give TXA with the thought that process that they're bleeding somewhere else. You can give it based on the protocols, you can give it for a suspected head injury, but the studies have mostly shown for hemorrhagic shock from other sources. So that's in the head injury section.
Got you. So we also have another question that came in. Does vomiting increase intracranial pressure?
Yes. So if you
Could
can
we
give
use
it,
Zofran
Yeah.
early to help keep this from happening?
yes,
So Zofran does play a role here.
yes.
Generally speaking, would you say that a patient, you're not kind of on the fence about TBI, if they start vomiting, it's a pretty bad sign?
Probably, yes.
Any role for steroids?
I don't think so.
And I know one thing that's kind of been confusing to me and probably to some others too is, you know, we did a study a while back on hypertonic saline
Mhm.
with trauma and head injury, and the results were pretty bad. And so I know I get confused sometimes when I hear people talk about the 3% or the hot salts. But I think when we did that study, it was way, way higher concentration. Than, yeah, it's really high. So are the studies showing there's an advantage to using the hypertonic saline?
Yes, I mean, and acutely, yes, especially if you think that the patient's about to herniate. So you want their sodium levels to be on the higher side of normal. So neurosurgery, if anybody who has a head injury, that with a obvious bleed, the neurosurgery is going to recommend you keep their sodium higher. So the best way to do that is with 3% because it's less volume, but a high salt concentration. But I've seen 23% used one time and it helped, but I've never given it any other time except for one GSW and a 4-year-old.
So the higher concentration salines essentially draw fluid into the circulation and out of interstitial. Is that the idea? Gotcha. Is there any danger there of precipitating cardiac dysrhythmias?
Not acutely, if there would be.
Not with.
I've never seen it, but
It's not enough to-
Not with 3%.
maybe it's 23%, but
Yeah, I think when we did that study that we had a couple of outlier cases that had some bad dysrhythmias.
Yeah.
That's the only reason I was thinking that.
but, I mean, 23% is a lot. It's like you're just putting salt in their veins.
So someone also asked, is there a different level of concussions after someone is cleared well from a concussion? If they suffer another one at any point, can it be the same level of worse in regards to having one previously? I guess they're asking what's the cumulative effect in a short period of time of concussions? Or is that something we need to even worry about?
I mean, it's definitely something you should worry about, especially if you're, are going out to a football game and you see the same kids every week. Obviously, if they have a concussion one week, they're still having a headache, and then they get hit again, and they get another concussion, you start worrying about them, but then you're getting into, what's it called, Taylor?
Yeah, the NFL stuff.
TBI.
Yeah,
Yeah.
yeah,
Yeah, so the big risk is if you have not completely recovered from your first concussion, right? So we know there's bad outcomes if you get reconcussed before completely resolving your first concussion. But like Julie was saying, there's no definitive data of long-term effects. There's some that says, yeah, it's bad. There's some that says, it might not matter. So we just don't know.
yeah.
So someone else asked a question. I'm not sure I understand the question, but I'll read it to you. Any thoughts on when we should be thinking about taking airways in the TBI stroke patients, other than patency of an airway and other thoughts such as initial GCS scores? I think you kind of covered that already. It's kind of a
Combination of
mixture
all the above.
of things, right?
Yeah.
Would you think, the old adage in EMS is that GCS is less than 8 intubate, less than 8 intubate? I'm not a big fan of that because
I
it's
think
just
you
not
have
always
to-
true.
To think about the whole patient.
And that's fine, but you still have a gag reflex.
Yeah, you just have a gag reflex and you don't have
It's
the
not
fall.
gonna matter if you don't have RSI.
Right.
Yeah.
So that brings up an operational question. If you kind of got a long transport to the trauma center, the head trauma patients might be a better candidate for helicopter, right?
Yeah,
To get the RSI
You have a
capability on
long-
the scene.
a long transport, or, if there's no helicopter available, if it's raining or storming outside, you can always divert to a closer facility to intubate and then go on to the trauma center after that. If they have a gag, you can't RSI them, but you don't want to bag them for 45 minutes to an hour.
So pros and cons there too, right?
Yeah.
So just making a best decision based. Thanks, great lecture. Anybody in the room have any questions for Dr. Brown on CNS injuries?
I have a question. When you were talking about minor TBIs, you said you're not really taking prophylactic measures as far as seizure medications. But then, I may have misunderstood, but when you're talking about moderate to severe TBIs,
They are recommending.
so you're
prophylactic
saying
meds.
like, just give it.
Yeah, because their risk of having status and that status causing worse outcomes is so much higher in a moderate to severe TBI. The risk of having a seizure with a mild TBI is pretty low, unless they have like a head bleed on CT, then their risk might be a little bit higher. So you don't have to prophylactically, you will treat a seizure, but you don't have to give them Capra, just empirically. But with a moderate to severe TBI, usually neurosurgery will recommend starting them on Capra or another anti-epileptic, at least for, 6 months or so.
But what about like in our position, like in the field,
Yeah.
is that something that?
I mean, you're not gonna have, Capra or Depakote or anything like that. If the patient has a seizure, I would give them Versed, to get them out of it, but you don't need to give them Versed in preparation for a seizure.
Okay, that's what I was trying to.
Just if they are seizing, then give it to them.
All right, guys, well, we're going to get started. We're going to kind of go over a hodgepodge of different topics today. I'm going to focus a little bit on ventilation, mechanics of ventilation, and then really going to harp on capnography and kind of get into the weeds a little bit with capnography. I think it's important to understand what we're actually looking at to better realize what changes in that number actually mean. So we're going to kind of harp on that a little bit later. So we are going to talk about adequate and inadequate breathing, talk about difference in respiratory distress versus failure, what things you want to be thinking about and looking for in those specific patients. We're going to talk specifically about alveolar ventilation, what that means, what that is, why do we care about it, versus minute ventilation. We're going to talk about the differences in oxygenation and ventilation, why those are important, and what that also means. Talk a little bit about effects of circulation when we switch over to positive pressure ventilation and things to think about, especially when we're talking about CPAP. We'll talk a little bit about ventilators, not much, it's not going to be a ventilator talk, and talk about some airway adjuncts as well. Okay, so let's get some of the basics out of the way, right? So we have to go through some definitions here. So minute ventilation is the amount of air that a person moves in and out in 1 minute, okay? And that's going to be just the multiplication of their tidal volume versus their rate, their respiratory rate, right? So respiratory rate is how many times they breathe a minute, and then you multiply that by the actual amount of volume that they take in each breath, okay? Usually measured in mLs, milliliters, and that will give you a minute ventilation, or the amount that they actually ventilate over 1 minute, okay? And it's important to assess this and look at this when we're thinking about different pathology changes in pulmonary. So adequate versus inadequate breathing, y'all do this every day when you come upon a patient that is complaining of breathing difficulty, right? So, are they adequately breathing? Are they in respiratory distress, or are they in failure, right? If adequately breathing, there's probably more support that we need to do rather than active management, okay? Do we need to give them some supplemental oxygen, give them some albuterol, kind of think about, is this something else going on? Is this a PE? Is this a carbon monoxide poisoning? Versus inadequate, right? So those are clear signs of respiratory failure when you come up immediately on the patient, and it's something that requires very aggressive management up front, because respiratory failure will immediately lead to cardiac failure, right? And very little time. And then we have this also concept, we talked about minute ventilation, but we have this concept of alveolar ventilation. So what is that, right? So the alveoli are the little bitty sacs in the very smallest bottom portion of your lungs that actually facilitate gas exchange, okay? Very thin membranes, and that is actually what allows the gas to diffuse between that little sac and the bloodstream that lies just beside it, okay? This alveoli. And so alveolar ventilation is the actual amount of respiratory changes and gas exchange at that alveolar space. Okay, this can be different from minute ventilation that we'll talk about. So there's different things that can affect each one, right? The biggest thing we care about is alveolar ventilation, because that's what how much actual gas is arriving to the alveolar space. That's what actual gas is diffusing across that membrane. That's really what we care about. Minute ventilation tells us how much air is moving in and out of the lungs, but it might not lead to actual alveolar ventilation because of COPD, asthma, pneumonia, fluid in those alveolar spaces. So it's important to think about the differences here. And so this is a good example, right? So here we just have in the middle the bronchus coming down, tracheobronchial tree that splits up in two different alveoli, okay? So on the right here in the right bottom right, we see gas exchange at the alveolar space. That's the actual alveolar ventilation that's occurring. And you can see if everything works right, you have good cross of oxygen into the bloodstream and CO2 back into the alveoli to be ventilated out. And then on the left side, you can see, say if you have a pulmonary embolism where you're getting no pulmonary blood flow to that one alveolar spot, you have zero alveolar ventilation on that side, okay? Now that might not occur across the whole pulmonary structure, but just that one side can lead to a shunt and can decrease gas exchange overall. You'll hear us talk about dead spaces. So that's just portions of the lung that does not actually participate in diffusion of gases. So the alveoli are the ones that are actually participating in diffusion. The trachea, the bronchus, all the way down to those little sacs actually does not participate in air exchange. So you can think about all the air has to travel through those spaces, but they're not actually participating in gas exchange. So they're called dead spaces. All right, so we talked about this a little bit. This is more of assessment when you come on scene, right? Things you're looking at for respiratory distress versus failure. Again, respiratory conditions are dynamic, they're ever changing. You have to pay really close attention to these patients on scene. And you have to know when to intervene, right? When have they crossed the line from distress into failure? When do I need to get a BVM? Or have they already gone to the point where I need to intubate them, okay? So with distress, you might have altered respiratory rate. They may be anxious. You might have a little bit of mental status change, but not a lot. You may see some changes in your oxygen concentration, right? That's going to be affected by oxygenation and not ventilation. So this would be an example, right? This is your classic COPD patient that's in every single textbook that was written, for the last 50 years. So what are some things we see here? Obviously, you got the wide eyes, nasal flaring. Everybody talks about tripoding, right? And that's really just to get those airways stented as the patient can. That's a big part of why patients tripod. You'll see wide eyes we talked about, retractions in between the rib spaces. You'll see pursed lip breathing. So does everybody know what I mean when I say pursed lip breathing? Has everybody heard that term before? So you'll see patients which when they breathe, they'll hold their lips tightly together when they're exhaling. And what are they doing? Does anybody know what is going on when they do that? So it's not like the patients think, oh, I'm just going to do this because I know what's going on. It's just subconsciously they're doing this to create a back pressure, okay? So we'll talk about PEEP, I think, in the next couple of slides. So PEEP is your positive end pressure that the alveoli see. So this, you can think about it as the pressure that the alveoli see in the end of the airways. And that is what helps the alveoli stent open, is that pressure, okay? Because if you exhaled all the way out of a breath, then those alveoli would collapse, okay? And then you'd have to have extra force and extra pressure to pop them back open. So that's why PEEP is great for these conditions, because it stents open the airway. All the air does not exhale all the way, and it will stent open the airways. So when patients purse lip breathe, they're actually subconsciously creating a auto PEEP, right? They're holding a little back pressure on the exhaled air, and that allows the air to not escape all the way and have some positive pressure at the end of exhalation, if that makes sense. So you'll see that a lot with COPD ears, the chronic emphysema patients. And then, so you're seeing a patient, they're in respiratory distress, you're concerned, you're getting all your equipment ready, you're providing them supplemental oxygenation. These are the things you want to look out for, right? You really have to try to catch this before it gets to this point. So respiratory failure, the biggest thing you're going to see is altered mental status, okay? That's going to be the first thing that starts declining. The respiratory rate might increase, but it might actually start decreasing to a normal level because they're not able to compensate anymore. So you might think, hey, are they getting better? They're not breathing as fast, but actually their mental status is worsening. They're getting to the point of respiratory failure. Some people call this tiring out, okay? Of course, you'll see accessory muscle use just like in distress. You'll see more of the head bobbing, and that is from not only the breathing, but also the decreasing mental status. You'll just see people kind of doing this number and start, looking down and things like that. That's all related to the mental status and tiring out. You can see some decreased O2 sats, of course, cyanosis, hypercarbia. We'll talk about those a little more when we talk about differences in oxygenation versus ventilation, which is important. All right, so CPAP. So what is the advantage to CPAP, right? Why do we use CPAP? Again, CPAP all revolves around what we just talked about with PEEP, okay? PEEP is great for patients with obstructive airway diseases, COPD, and again, it helps to stent. You can think about it as stenting open the airways, okay? It provides PEEP. It allows them to exhale the air out of their bronchi, okay? We'll talk about, I think it's this next slide, or in a couple slides we'll talk about. You can see some help with oxygenation issues, but really CPAP is more for ventilation, okay? And so we can go ahead and talk about difference in oxygenation and ventilation. From the alveoli to the bloodstream, okay? Ventilation is a totally separate thing. Ventilation is the getting rid of the excess CO2 in your body, okay? So basal metabolism, every day, everything we do, the body will produce CO2, okay? On a cellular level, it produces CO2, which gets transferred to the lungs. That CO2's got to leave the body, or if not, it makes the bloodstream acidotic. So that's one of the primary responsibilities of the lung is to get rid of the CO2. So that is a ventilation section or category, not an oxygenation. Two separate things, and you can have problems with each one without problems with the other. So you can have a ventilation issue and have normal O2 sat, right? And vice versa. You can be ventilating fine, but have an oxygenation issue. So this helps more with ventilation more than oxygenation. Yes, you can provide supplemental oxygen through this, but it's really more of a ventilation support. So again, this is kind of an example of PEEP, right? That end-expiratory pressure that you're trying to increase, and that will keep those alveoli from collapsing at the end of each breath. And that's all we're really doing with CPAP. So this is a picture of COPD. In the bottom, you can see what's actually gone. So the top is alveolar sacs. These are beautiful, healthy alveoli, kind of grapes on the end of a stick there. That's what normal alveoli look like. And at the bottom, you can see, you know, all the septum and different areas have kind of congealed away, and it's kind of one big sac, okay? And then what also happens is the bronchi, you can see at the bottom, they get filled with you know, chronic infection, and also the walls become floppy. The walls become very floppy. So as you breathe out, those airways will collapse, and it will not allow the air to fully release. And that is the major issue with COPD, is you're actually not getting enough air out, okay? COPDers will have no problem getting air in, they just can't get air out. And it's the same way with asthma. All right, so talking about CPAP, of course, contraindications. The patient has to be able to maintain their airway on their own. I've seen a lot where patients will come in, EMS crews will have them on CPAP, but they're really not oriented or with it enough that they should be on CPAP, because it is an aspiration risk if patients cannot protect their own airway. So if you have a patient that's altered enough that can't protect their airway, they really don't need to be on CPAP. Severe hypotension is also a contraindication. And that is more on the fact that CPAP will decrease your preload. Okay, so normally when we breathe every day, we use negative force, right? We have the diaphragm up here. When we take in a breath, the diaphragm goes down, and that creates a negative pressure inside the chest cavity. Okay, that negative pressure will suck air into our lungs. Well, that also helps suck the blood into the venous system on the right side of your heart. You can think about it that way as well, right? Because your heart sits in your thoracic cavity as well. So actually you taking a deep breath is helping that venous side return blood to your heart. So what happens when you switch over to positive pressure ventilation, right? The body is not sucking air in now. We're actually putting a CPAP or a BVM, and we're forcing air into the lungs with positive pressure. That eliminates that chest wall ability to suck venous blood into that right side, okay? So that's why CPAP and positive pressure ventilation is bad for hypotension, because it's going to decrease that preload even further on the right side of the heart and make you even more hypotensive, okay? Now, this can be helpful in the setting of heart failure, right? So we got that heart failure patient that their systolics are 220s, they got pulmonary edema, they got rails bilaterally, right? We slap on BiPAP, because that helps for several reasons, right? It pushes the fluid out of the lungs, and then it also decreases preload, which is good in that setting, because in heart failure, we have too much fluid on the heart. So, all right, so that's kind of what we're talking about here. Normal patient negative pressure is what creates ventilation and facilitates venous return of blood flow, right? So, you know, we all know this. Usually we'll say if patients are altered, their ventilation rate is less than 10, you know, we need to jump on and start being aggressive with our management. For oxygenation, most people will say less than 94%. It depends on what specifically we're treating, but less than 94%, usually we'll need to add supplemental oxygen with a caveat of COPD patients, right? We are fine with them bringing 88 to 92%. That's usually where they live anyway. Okay, we'll talk about some airway adjuncts briefly. OPA, NPA, these are great. I really feel like these are overlooked in some of the EMS world. They can be great if you're bagging a patient. A lot of times these are just kind of over to the side and forgotten about. But especially if you're bagging a patient, these are great airway tools to use, okay? So we can talk about OPA. My notes real quick. So OPA, it's rigid, right? So it's not like an NPA that's kind of flappy and malleable. OPAs can, of course, only be used in a comatose patient, right? Because the gag reflex is not going to allow you to actually place the OPA on these patients. Size, again, just to remind everybody, it's measured from the corner of the mouth to the angle of the mandible. And then you got to remember that when you're inserting it, you do the little twisty twist thing where you put it in backwards, then you rotate it 180 degrees once it starts going in. And that's just to facilitate it easily going around the tongue when you put it in. And then NPAs are great as well. You can use these in awake patients, right? So these are great for those semi-obtunded drug overdose patients that you're somewhat concerned about their airway. You can slap this in and monitor them on the way to the hospital. It's great for that. It's more pliable. You do need to use a fair amount of lubrication for these, and sometimes you just can't get them in. Sometimes people's nasal structures are just in a way where the anatomy doesn't allow for you to pass them in. And then, you know, we've had different lectures on these as well. So there's all the different SGAs that people are using now. Most recently, the IGLs become very popular. People still using the King as well. They're blind insertion airway devices, right? EMTs can now use them in the state of Alabama. I think over the last couple of years that was implemented. We've talked about this a lot, so I'm not going to go into detail much with this. And then, of course, endotracheal tube, right? Gold standard of airway management. Protects from aspiration, which BIADs don't, SGA or IGL, right? You can suction if you need to. The route of drug administration, that kind of was a former thing. We really don't recommend that anymore. Difficulty is, of course, is the training. Initial training is difficult. Skill maintenance difficult. You know, if you don't use it, you lose it with anything. So ventilators, not a lot of EMS ground-based services use ventilators. They're good for long transports. Again, this is not a ventilator talk, but the big thing you got to think about ventilators is you're switching the patient again from negative pressure to positive pressure. So you really got to think about their hemodynamics when you put patients on this, right? Because it is going to affect their blood pressure. All right, so that was a quick view through on some of the basics. Now we're going to go into capnography and kind of get a little bit in the weeds of that. Any questions so far on that?
Just a little bit of chatter about, so just to clarify.
Yes.
So positive pressure can create a decrease in blood pressure.
Yes.
So that can happen with CPAP, BiPAP, or BVM.
Or BVM, yeah.
Right. Yeah. So, but in the setting of respiratory failure, respiratory arrest, they need to be ventilated.
Yeah, that's cool, of course.
Yeah, no matter what their blood pressure.
Of course,
Yeah.
yes.
So
So, yeah. So it's kind of like a necessary evil. It's just something you got to be aware of, right? And if you have the ability to push dust pressure or pressors or whatever, it's just something you got to think about.
And volume and rate is important there too, right? Because it's easy to overventilate, and that, so if you overventilate, that even exacerbates that effect even more.
Yeah. Yeah, because there is a entity where if you ventilate too much, you can create breath stacking, or auto peeping is what it's called, where you won't exhale all the gas and you'll just have more of a buildup of pressure in the chest wall, and that will just further decrease preload and venous return.
Got it.
Yeah.
All right, cool. All right, let's go into capnography, right? That's what everybody's waiting on. Let's do this. So we're going to talk a little bit, well, we already talked about difference in oxygenation and ventilation. Capnography is really looking at ventilation, right? It's not looking at oxygenation at all. So we'll talk about that. We'll talk about how we can basically take the end-tidal CO2 and use it as a surrogate for a blood gas. Okay, that's why it's helpful in a lot of different patients. And we'll talk about the basics of the waveform and how to read it and all that good stuff. So first off, oxygenation, right, is different from ventilation. Oxygenation measured by O2 sats. We're actually looking at the percentage of hemoglobin that is saturated by oxygen, right? So when we're reading that percent, that's what we're actually looking at. How much hemoglobin is saturated on a percent basis. Okay, it does take a little while for this to read. So basically it's not in real time, right? So it might take 2 or 3 minutes for your pulse ox to actually correlate to what is actually responding at the cellular level, which is different than End-Tidal. End-Tidal is more immediate. So you may have seen this before, the oxyhemoglobin dissociation curve. This just relates your PaO2 to your SaO2. So basically on the left side, you can think about that's your oxygen saturation that you're getting on the monitor, right? So you got 0 to 100% on the left. On the bottom, you got PaO2, which is just the pressure of oxygen on the artery side. That's basically all it means, okay? So, you know, anywhere from 60 to 100 is normal, and you can see that correlates. So 60 is about 90% O2. And the biggest thing that why I wanted to show this is that it's not a straight linear curve, okay? So patients can hang out in between 90 and 100% for a while with various differences in your actual oxygen in your bloodstream. And you can see once you get past that 90, it's a huge dip down. Okay, so that's why you can see these patients, they're like, well, they were at 92 for a while, and then all of a sudden looked up and they were at 60, right? It's a logarithmic curve. It's not a linear curve, and that's why you can see that. So End-Tidal CO2. So End-Tidal CO2, right? It's used to measure ventilation. It can be a surrogate. What we're actually measuring is a partial pressure of exhaled CO2 that's exiting the airway, and we're measuring that one number at the end of exhalation, right? So that's the number that it prints out. End-Tidal CO2, it's a breath-to-breath measurement, right? So we can get info within seconds compared to SpO2 or oxygenation, which will take a couple minutes to actually get a good reading of what's going on at the cellular level. It's not really affected that much by motion artifact, which is great. You know, if you have a lower perfusion, it will read out still accurately. And if you have dysarrhythmias, it'll still read out accurately. So there's not a lot of things that will throw it off. It basically measures the CO2 at the point of exit. Okay, we'll talk about each part of the graph and what each one means. So again, we want to measure how much CO2 is in the blood to see how our lungs are working, right? Are they getting enough CO2 out of the body? Okay, so normal range at equilibrium is about 35 to 45 millimeters of mercury. That's normal. And we can measure this. We can take a blood sample, get a blood gas, and actually measure how much CO2 is on the artery side or the venous side, just based on if we do an arch stick or venous stick, right? And that will give us a direct measurement. Well, End-Tidal can actually give us a surrogate measurement of that without having to get blood, okay? And that's why it's helpful. Now, there is a little difference between the blood content of carbon dioxide, CO2, and what we see on End-Tidal, but it's very minimal. It's less than 5% difference, okay? And that's just a difference in dead space in the airways, okay? But knowing that, we can anticipate, oh, it might be a couple millimeters here, less or more, but it's not going to matter overall in the big picture. So it's a pretty good surrogate. So again, this kind of gives us the idea behind what we just talked about, right? So there is this idea of End-Tidal gap, which I just talked about. So there is a small difference between the content of CO2 that's in your blood versus exhaled. That gap can widen under some circumstances, right? So if your lungs are not working as well, if there's a pneumonia, if there's pulmonary edema in those alveoli, right, you can have buildup of CO2 that's actually not being exhaled as much, and that gap will be larger. So it's just something to think about. Ultimately, End-Tidal is measuring three things. It's telling us information about ventilation, right, just movement of air in and out. Patients with asthma, COPD, If you actually have a foreign body obstructing the airway, right, those will all affect end-tidal CO2. A stroke, which would lead to airway issues. It also tells us if there's a diffusion issue, right, the actual gas exchange at the level of the alveoli, right, that has to be working appropriately for you to get a good end-tidal reading. Things that could affect that, if there's fluid, if there's pneumonia, if there's actual alveolar damage or alveolar hemorrhage in the area, that will affect diffusion. And then it also, what's cool in EMS is it gives us information about perfusion. So in the normal healthy person that has a pulse, perfusion, when it goes high or low, should not affect end-tidal that much. The big thing we see is in cardiac arrest, right, where we have almost little to zero perfusion to the lungs. That is where it really affects end-tidal, and that's how we can use it in cardiac arrest to tell us important things. So why measure, right? So intubated patients, of course, it's going to be helpful to verify that the tube is placed, right? That's very important in EMS. We have to have that documented on all charts, use of waveform capnography to determine if the tube is in the right spot. It can tell us effectiveness of chest compressions, right? And that's based off the idea that it assesses perfusion to some level. And then it could also be used to tell us, hey, this person now has a pulse. We had a very low end-tidal CO2, and now we have a huge end-tidal. Hey, we have perfusion all of a sudden back to the lungs. That means we have ROSC. It can tell us it can let us estimate how successful we think the resuscitation is going to be. If somebody is getting good chest compressions and they have a low end-tidal CO2, that can be an indicator that they're not going to survive the cardiac arrest. So there's a lot of different things that's useful in the intubated patients. And then also the patients that are not intubated, right? So in patients with COPD or asthma, it can tell us, hey, are they ventilating appropriately? It can tell us, hey, did our albuterol treatments, did it help? Did it not do anything? It can tell us if somebody's altered from a drug overdose and they're not ventilating as much. It can tell us in DKA, right? Okay, this patient's DKA, they're breathing 50 times a minute. If you didn't know it was a DKA, is this a respiratory issue? Well, their end-tidal is super low, so they're hyperventilating, right? So maybe it's not an airway issue, maybe it's DKA or a metabolic issue. So there's a lot of different things end-tidal CO2 can tell us. All right, so we're gonna go into somewhat of the details of the actual waveform. I think it's helpful to know what we're actually looking at in regards to this. So the height of the waveform is the amount of CO2. Okay, the actual height of the waveform is the amount of CO2 that it's reading. The length of the waveform is just the time, right? So just as time passes, just like anything else. There is a baseline, which is zero CO2. The printout is real time. And we're going to go over each specific little section of it, okay? So again, this is a normal end-tidal CO2 capnography waveform, okay? You have an upstroke, you have this plateau phase, and you have a downstroke. They're divided in different phases. We'll talk about each one and what portion of the breath cycle it's in so that we all are kind of on the same page here, okay? All right, so phase one, down here at the bottom, we're at baseline. This is inspiratory. So this is actually when the patient is taking in a breath. You have zero CO2, which makes sense, right? The patient's taking in breath. You shouldn't have any CO2 in the reading. So that's phase one. As they start exhaling, right here, actually before the upstroke, they start exhaling. And so why is this zero still if they're exhaling, right? Well, that's part of what we talked about, the dead space in the lungs. The air starts to move out. The first air that you see when you start exhaling is dead space. So there's actually not going to be any CO2 in that. So that is phase one, right? Mostly inspiratory, and then a little bit of expiratory is phase one, where you're at baseline of zero. So phase two is when you get a rapid acceleration or rapid increase in your CO2, right? Now you actually have the CO2 that is in those alveoli mixing together with the dead space as you continue to exhale, and you get a rapid rise in CO2. Okay, so that's all we're measuring here. Phase three is the plateau at the top that we're looking at. So now we've gone from dead space to dead space mixing with the CO2 rich gas to now we're basically only looking at the air that was coming from the alveoli, okay, which is CO2 rich. And that's why we have this plateau phase here. Okay, And then you can anticipate phase 4, the descending phase, is when you actually start to breathe in, and it immediately drops to 0 as you take in a deep breath. So the actual readout number that you're getting is right here at this top corner, okay? So this is going to be your end-tidal, so tidal volume, right? The air you breathe out, the end-tidal CO2. So the end phase of the phase 3 expiratory plateau, that's the actual readout number that you're getting, and it correlates on the graph to the number 35, 45, whatever it is. So that's what you're actually looking at, right? That's the whole breath cycle. Inhale, exhale, and it just repeats itself over and over again. So now that we know kind of what a basic waveform looks like, we can talk about how this may be affected by different pathology, right? So again, top left, I love this slide here. It's got everything on one. It's got some good descriptions if y'all want to take a screenshot or something to go back and review this, because it's got some really good data on it. But so we can go over some of it. So again, normal waveform, top left, you have that good looking plateau. You can look quickly at this waveform and get a respiratory rate based off of this, right? So the next big one people will talk about is the shark fin appearance. You'll see a shark fin, okay? So that's the second one. That's going to be any kind of your reactive airway diseases, your bronchospasm, right? Whether it's asthma or COPD. And if you think about it, what's happening, right? What's going on with the waveform? Well, you're actually, again, remember with COPD, emphysema, you're having difficulty getting the air out. It's a obstructive process in the small airways of getting the air out because of this flappy septum, okay? So all you have is just a slower amount of time before you reach that peak end-tidal CO2. That's all you're reading, right? Instead of a quick exhalation, you get that CO2 rich air from your alveoli. It just takes longer for you to get to that top point, right? So you don't get this plateau, you get this kind of slow rise to peak, and it's called a shark fin, and that indicates, hey, there's some obstruction process, COPD, emphysema, asthma going on. So this one here, you can see, so this is a normal waveform, right? Well, some time goes along, you get another waveform, but it's higher. It's higher than the first one. And then you might have another one that's a little higher, right? So what's going on here? So this means that the patient is not adequately ventilating enough CO2 out, okay? So this could be drug overdose. We see this a lot in patients when we're giving them sedation in the ER. We're monitoring this. You know, they start not breathing as much. Their end-tidal will start rising, and the distance between their breaths will start getting longer and longer, okay? So this is kind of the stacked appearance that you see with hypoventilation. So the exact opposite in hyperventilation, right? You see more breaths together, and you see slowly a decrease over time in end-tidal CO2. That's just you're breathing off more gas than your body is actually producing. So each breath that you exhale is a lower CO2 level. This one's, you probably won't see it a lot unless you deal with ventilators a lot. But you can see here we have the stacking just like we have here. So we have increasing end-tidal CO2, but you notice we never return to the baseline, okay? This is usually a faulty exhalational valve on your vent. It could be also an indication of what we call breath stacking. And it's just an indication that you're not fully exhaling all the air. So before you exhale all the air, you're actually taking another breath in and you're rebreathing some of that CO2. You're rebreathing some of that CO2 again, so you never get back to your baseline of 0. This cure-rare clef, you'll see if patients, you see this a lot if patients are mechanically ventilated or intubated, right? These are patients that are taking a spontaneous breath. You won't see it really in any spontaneously breathing patients. And then if you look at these last two things, right? So this is what's really helpful in cardiac arrest. So this is different than this. I don't want you to get confused. We're not looking at the same scale here, okay? So this is not looking at waveforms anymore in the bottom right here. This is just looking at the over time. So this is a 30-minute trend graph and just looking at your end-tidal CO2, okay? So you can see here, the really important thing with end-tidal, besides tube placement in cardiac arrest, is looking for spontaneous return of spontaneous circulation, right? So you can see here, this patient had CPR going on for a while. They were in the 20s, right? And then you see maybe a defibrillation, and all of a sudden end-tidal jumps up 60, 70, 80, whatever it may be. And then it slowly returns back to baseline, okay? So that'd be evidence of ROSC, which is super helpful, right? It means less pauses to check for pulse, Helpful all the way around. Okay. Also, you can see, you know, is your CPR appropriate, right? Are your chest compressions appropriate? If you have somebody that was a witness arrest, a VFib arrest that you're trying to shock out, you're doing CPR, you know, not a lot of downtime, and you look and your end-tidal still 10, you're like, it should be better than that. Maybe it's the issue with your rescue or compressions, right? Maybe you need to increase your depth of compressions, increase your rate to get better perfusion. So that's also something that's very helpful that can tell us about. Again, this is the shark fin of obstructive disease we see with end-tidal CO2. That was a very quick overview of the waveform. Everybody understand? We have any questions about the waveform online? It's really important. This is something that you kind of got to sit with a graph and look over to actually understand what's going on. But once you understand it, it all clicks, and you can immediately look at a waveform and say, oh, this patient's underventilating, this patient's overventilating. You know, so it's important. It's very helpful.
Just a couple of quick points. One is that cleft, and I can't pronounce the
Pure air cleft, or I don't know. I don't know if that's like that.
So we see that a lot in cardiac arrest resuscitation.
Yeah.
Which is a good sign, right? Means the patient has some ventilatory effort.
Yeah.
But over and over again, I see people on the scene think that that means the cuff is leaking. So what does the waveform look like when the cuff leaks?
So you shouldn't, if the cuff is leaking, right, it should be less end-tidal CO2 because, right, you're having a mixture of air that's not CO2. So it should be less end-tidal. But more importantly, it should just not be a regular plateau. So if you're not seeing the up and down of a normal plateau, then there's probably some type of air leak or the tube's not in the right position. So, you know, unless the guy's been deceased for 30 minutes and you have a little end-tidal, you should, otherwise, besides that one specific case, you should see a good waveform. If you don't have that good waveform, there's cuff leak and tube's not in the right place.
So the other point was, you know, we're using the existence of a waveform to verify tube placement in the trachea. But we can get a false reading there that diminishes from antacids or carbonated beverages. So just if you want to touch on that.
Yeah, so what you got to remember with that is that there is theoretical where you can see a little bit of CO2 from the stomach if the tube's not in the right spot. But again, that's going to diminish. That's going to diminish very quickly. Right. So that's
like 6 breaths, right?
Yeah, very quickly. And you will not see the great up and down, right? Because if you're pumping air into the stomach, it's not a confined space. So you're not going to see this beautiful plateau where if you're actually in the lungs, it's a confined space that you're actually ventilating. You'll see the good waveform. So that's kind of the indicator for that.
Got you. So the other one that was mentioned was the breath stacking that we see and shark fin are often combined in severe asthma.
Yeah, of course. Yeah.
So you have shark finning and stacking, and that should tell you that your treat, whatever you're doing, is not working.
Yeah, and sometimes even if you do everything you can, you may not be able to eliminate breath stacking altogether. But yeah, those go hand in hand, right? You're not getting enough air out. So if you start a breath before you get all the air out, you're not going to return to your baseline. So yeah, it makes sense that those two go hand in hand.
Cool. Oxygenation, we already talked about this a little bit, just a very quick, you know, this was a AHA guidelines. I think this was actually from 4 or 5 years ago. But there was this concern for oxygen-free radicals, right? Especially in STEMI patients or patients with CNS injury. Yes, we don't want patients to be hypoxic, but again, also if they're saturating normal, we don't want to just give them oxygen to give them oxygen. And the one caveat is, yes, if you have a STEMI patient that you're really concerned about, if they're looking like crap and you're concerned they're going to go into VFib any minute, you may throw on some oxygen just as pre-oxygenation in preparation for further critical therapies. But in general, if their oxygenation is totally fine, we've kind of gone away from just slapping everybody with chest pain on oxygen. So that was the only thing else I had briefly I wanted to talk about. Yes, we got a question.
Oxygen, like traumatic injuries, I know that it has like constricting, vasoconstriction, but is that more peripheral or is that central? Or like globally?
You mean for vasoconstriction for, so you're talking about like for CNS injuries and things like that?
Yeah.
Yeah. So hyperoxygenation will cause vasoconstriction. Same thing with carbia, but it shouldn't affect peripheral.
So it's centrally.
Yeah, and it's not, it was central meaning just CNS. It's more of a vasoregulatory mechanism in the CNS.
Okay, so high flow oxygen isn't going to reduce blood flow in like a hemorrhage or traumatic injury to the right arm.
Yeah, I would think so.
So we had some comments on some of the attendance forms wanting to talk about sedation post-ROSC of intubated patients.
Yes.
That we're seeing in the protocols. There seems to be a lot of confusion about that.
Okay. Yeah, so the protocols, I think, has 4 different drugs you can use for post-sedation. Again, this protocol was developed because we're seeing more and more people with the use of Lucas and just better cardiac arrest management overall. We're seeing more people actually have spontaneous movements and kind of coming back after you get ROSC. So this was introduced especially for patients with or for agencies with longer transport times, so that they can give some kind of sedating medication after a patient has been intubated and has gotten ROSC from a cardiac arrest. So yes, there's 4 different drugs. I think it's Ativan, Versed, fentanyl, ketamine. I think it's important to talk to your offline medical control about what would be most appropriate. I would probably lean for specifically post-ROSC patients. I would lead to either fentanyl or Versed. That's kind of my go-to, and I'm more of a Versed guy. If you think it's a cardiac STEMI, right, a STEMI that led to a VFib arrest, you're not going to want to give them ketamine. That's going to increase their heart rate, blood pressure. That's just going to increase their cardiac demand. So I would stay away from ketamine in that situation. And then we talked about yesterday, actually one of the protocol classes, if you're concerned for like a fentanyl overdose and somebody has arrest and you give them a bunch of Narcan, you just got to think about it. If you give them fentanyl now, that fentanyl's not going to work if you gave them Narcan. Okay, so I would try to stick to Versed. If there's a slight risk of having a little blood pressure effects with Versed, but it's not a lot. So I would stick with that. Were there any specific questions about the confusion, or?
No, actually, somebody just asked that we talked about it under
Okay.
comments of their attendance form.
Yeah.
So, yeah, I think that's good. I think we'll probably have to revisit it a few times.
Yeah.
Because it's just a new idea.
Yeah. Yeah.
And I think it speaks to how many patients we're achieving ROSC on now as compared to in the past.
Yeah. And what happened in the past, right? You just tied down their arms and tried to get them not to pull out the tube. Well, now you actually have an option to sedate them. So you get
Often they have to pump their arms, but.
Yeah.
Because the pump is them as well.
So one of the things that we're talking about, I know in the skills labs at EMS Challenge, is how when you're using a bag valve mask with oxygen attached to it, and you're holding the mask with a good seal to the patient's face, the patient actually isn't receiving any supplemental oxygen except for when the bag is squeezed, which is another reason to use the apneic oxygenation. So just some thoughts on respiration being driven by concentration, ventilation being driven by pressure.
Yeah.
How, like in a cardiac arrest, how does the apneic oxygenation help in the patient?
So apneic oxygenation, it really helps 2 ways. So if you turn on high flow oxygen, so just to get a baseline, apneic oxygenation is the term we use when somebody is apneic, right? They're not breathing, they're not ventilating, but you throw on oxygen. Specifically, we use it in cardiac arrest to get some oxygenation. And the idea is that if you blow air into their lungs hard enough, you're going to wash out their lungs, and that in itself will cause some airway exchange, right? If you give enough force with oxygen through the nose, it will flush out some of the CO2. And then there's also the idea that as you're doing chest compressions, you're going to be ventilating some just from the chest compressions themselves. So if you have oxygen on board, that's just going to help that more oxygenation aspect more.
So they're getting, in that way, they're getting a high concentration in the conducting passageways all the time, not just when you're squeezing the bag.
Yeah.
So different once they're intubated, right? Once they're intubated, then obviously.
Then you're controlling how much oxygen they're getting. Yeah.
Yep. Anybody, in the class have any questions? Nope. Well, very good. Thanks to everybody online for joining us today. Please remember to fill out an attendance form, even if you don't need the credit. It's a good way for us to get your feedback. We do read all of it. And, also we want to, make sure that we get an accounting of how many people we're reaching. Our next session will be 2 weeks from today at Birmingham Fire Drills and Training South, which is at 611th Street South, upstairs at Station 2. And that session will have a skills lab afterwards. If you're in the area, I would encourage you to come participate. We'll be providing lunch as well. The critical care, for the helicopter folks and critical care folks conference, national conference is in Orange Beach. And that's coming up. If you're interested, you can look that up on the web. And got a lot of exciting stuff happening in EMS. Everybody remember that the new protocol is going to effect on April the 29th. So you should be engaging in protocol education. Make sure everybody gets up to date. And thanks all for participating. We'll see you next time.